Hello, this is Martin Altersberger speaking for Heart and Lungs Ultrasound. In the last couple of videos, we talked already extensively about diastolic dysfunction, myocardial mechanics, individual measurements. And now it is time to continue talking about also our guidelines, because not only it's important to know the measurements, but it's also important, and I was talking about it already quite extensively, to define are there normal or elevated filling pressures present. And in the guidelines, a very important topic I think to discuss is the situation of indeterminate filling pressures. So we have to differentiate, do we have a healthy left ventricle or a diseased left ventricle? And I want to show you now a graphic from the guidelines from 2016. And in patients with normal left ventricular ejection fraction, but keep in mind this means a normal left heart. So we also do not want, and that is written in the detailed text, change in, for example, wall thickness. So patients with a normal ejection fraction and a normal heart dimension fall into this category. So for me, very often this will show normal filling pressure. So here you have rarely, in my point of view, 50% positive, so that you define diastolic dysfunction. So when less than 50% are positive, filling pressures are normal. When the right side, so more than 50% are positive, then you have an elevation in filling pressures. And in the middle, so when you have the measurement of, for example, average E to E prime above 14, the lateral E prime velocity below 10, TR velocity of 2.6 meters per second, and the normal left atrial volumetric index, you have an indeterminate situation. This is, for me, the rarest of the rare, because when you have a normal left heart, so not only a normal ejection fraction, but the normal systolic function, so for example, a normal global longitudinal strain, normal left ventricular dimensions, normal dimensions of the interventricular septum of the heart walls, and the normal dimension of the left atrium, how is it possible then that you have really a diseased left ventricle with an elevation in filling pressure? So this needs, when there's truly about 50% positive, some more thoughts. If you truly see diastolic dysfunction, elevation in filling pressures, and why they might be there. Displayment of examples of normal left hearts. We have several 4-chamber views, some focus on the left ventricle, some subcostal views, but we do see, for example, here normal size of the left ventricle, normal left ventricular walls, here the same, a normal size by means of body surface area of the left ventricle, left atrium, right ventricle, no thickening of any heart walls, and normal left atrial function as well. So you can also eyeball left atrial function, you see that it's dilating and contracting quite nicely. And you see the same in subcostal views. You have also visualization of the atria. The more common situation is especially in patients when you have a mitral valve inflow in reduced ejection fraction, but also in left heart disease. So if the left ventricle is diseased, we have to think, do we have normal filling pressures or do we have elevated filling pressures? As soon as you have a left heart disease, for me personally, it is a thickening of left ventricular walls, but also dilatation in, for example, solely in the left ventricle, but also when you have a dilatation of the left atrium, you have to think about, is there truly a left heart disease present? And when this situation occurs, we first have to take a look at the E to A ratio. And in the guidelines, if the E to A ratio is below or 0.8, plus the E wave below or 50 centimeters per second in a diseased left ventricle, for example, in patients with hypertrophic cardiomyopathy, amyloid heart disease, it doesn't matter. So also in patients with heart failure with reduced ejection fraction, when you have this constellation, the left atrial filling pressures are highly likely normal. And we define it with a number, grade 1 diastolic dysfunction. For me personally, it's very important to denote that filling pressures are normal. So left atrial pressures, left ventricular and diastolic pressures, that's actually a synonym without mitral stenosis, filling pressures are normal. When we have then a different situation, we have an E to A ratio below or 0.8 plus an E wave, which is now above 50 centimeters per second, or an E to E ratio, doesn't matter how the E wave is configured, of above 0.8 but below 2, we have more criteria to evaluate. We have to evaluate the E to E prime ratio. We talked about it. The cutoff for the E to E prime ratio is 14. So it's an average of the medial and the lateral mitral valve annulus. And if it's above 14, it's positive. The TR velocity above 2.8 meters per second is also positive. And the left atrial volumetric index above 34 milliliters per square meter is also positive. Now let's go to the left side when we have 2 of 3 or 3 of 3 negative. So for example, we have an LA volumetric index of 35 milliliters per square meter, but the TR velocity of 2.6 meters per second and the E to E prime of 8 to a negative, and we have normal left atrial pressures, normal left ventricular and diastolic pressures, a grade 1 diastolic dysfunction. Now when 2 out of 3 or 3 even are positive, we have a grade 2 diastolic dysfunction, meaning left atrial pressures are elevated. Also, of course, as a synonym, the left ventricular and diastolic pressures. So when you have an E to E prime of 16, TR velocity of 3 meters per second, left atrial volumetric index of 38 milliliters per square meter, all are positive and filling pressures are highly likely elevated. Continuing with the next situation, when you have only 2 criteria possible. So for example, TR velocity is not measurable. When TR velocity is not measurable, you have either 2 negative, then we have normal filling pressures, or 2 positive, then we have an elevation in filling pressures. When it's in the middle, so 1 is positive, for example, the TR velocity is 2.9 meters per second, but the E to E prime is 11 in a mean value, in an average value, you in the guidelines are still told you cannot determine left ventricular and diastolic pressures and left atrial pressures. So you cannot determine filling pressures or grade diastolic dysfunction. We have several measurements at hand which can be used in this case. For example, I'm a huge fan of left atrial strain, but also you can use the pulmonary venous signal, and in my point of view, also the pulmonary acceleration time we also discussed in a prior video. The other way around, when you have 2 positive, we said we have elevated filling pressures, and then we go to the restrictive filling pattern, the E to A above or 2. When you have an E to A ratio of 2 or more, filling pressures are definitely elevated, left ventricular and diastolic and left atrial pressures are elevated, and that is grade 3 diastolic dysfunction. We also know it as this restrictive filling pattern. Other considerations we had before the recent guidelines of 2016, the pseudonormalization, the impaired relaxation, that is not an accurate definition of diastolic dysfunction anymore. So you should stick to basically those measurements and definition of, is there an elevation in filling pressures present? Which grade of diastolic dysfunction do we have? Again, that being said, I'm a huge fan of defining, do we believe in our echocardiogram if filling pressures are elevated or if they are normal. Now, some examples of diseased left ventricles. You have on the left-hand side a patient with steroid use. So we do see that the left ventricular ejection fraction might be borderline normal, but the left ventricle is definitely diseased. There's some degree of LVH present, and overall you do see that longitudinal function is reduced. On the right-hand side, you have another example of a pathological left ventricle. This was a mid-ventricular Takotsubo syndrome. So you do see wall motion abnormalities in the mid-ventricular area. So of course, that's also not normal. Here, ejection fraction is borderline, probably mildly reduced, but I would stick now to borderline. In this case, left ventricular ejection fraction is definitely normal. So we do see in both cases left heart disease, left ventricular disease. When we continue with another example, we have a left bundle branch block. Filling pressures in left bundle branch block is difficult to assess. In this case, we have an ejection fraction which is reduced, but also a diseased left heart with, of course, the reduction in ejection fraction. On the right-hand side, we see a HFrEF situation, so heart failure with reduced ejection fraction, with also a left bundle branch block. You can see also there's already a CRTD inside. So here's then, of course, a reason now for this contraction. So this patient with HFrEF and left bundle branch block received a CRTD. So we can see the pacemaker leads here into the right ventricle and here in the right atrium and also in the coronary sinus. The coronary sinus lead also quite nicely displayed over here. You still have the severely reduced left ventricular ejection fraction, so another form of a diseased left ventricle. In this case, harder to see. This is a patient also with a heart failure with reduced ejection fraction with an apical scar. So in the B mode imaging, it's harder to see, but overall you can estimate that there will be a wall motion abnormality, but you might overestimate ejection fraction. In this case, on the right-hand side with contrast, you see the same patient. Here is the hinge point, so here is the thinning of the myocardium, and here basically we have the apical scar, but also in the lateral regions, the reduction in movement. Basically, there is no movement present, so this is akinesis of those segments in a patient after myocardial infarction. Now, more diseased left ventricles, in this case, another case of HFrEF heart failure with reduced ejection fraction with a severe dilatation of the left ventricle. You see 4-chamber, 2-chamber, and apical long axis view in this multiplane imaging, and we have this large area of akinesis. So ejection fraction also in this case was significantly, severely reduced.